to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back to the show. We have another very special guest, a personal mentor and friend of mine, Dr. Robert Hedaya, with us this week. Bob is a master teacher in the functional medicine world. He straddles the allopathic as well as integrative medicine worlds. He's a clinical professor of psychiatry at Georgetown, and he's also on faculty at the Institute for Functional Medicine. He's a teacher, author. He's been on national media. But he's always a clinician first, which is one of my favorite things about him. Please welcome to the show, Dr. Robert Hedaya.
Well, thank you, Nate. It's a pleasure to be here.
Yeah, I'm so glad that you could make the time. You know, Bob, you and I were recently in Florida together, and we met for a meal, and we talked the way men do. And
speak for yourself. Speak for
yourself. Well, it was all above board. It was, you're giving me some advice. And that same weekend, you went to a conference on the topic of, I think it was mild cognitive impairment. Mm-hmm. And rumor has it, you had it out with a group of physicians there about some things. Can you fill in the blanks there? First of all, is that rumor true? And then what actually happened?
Yeah. Well, what happened was it was a conference of probably 200-300 Alzheimer's, dementia researchers, clinicians, neurologists, a few psychiatrists sprinkled in. And it was a really mainstream approach to Alzheimer's. And it was very agitating because you could see that billions and billions of dollars were going down the wrong path, in my view. And so I decided that on the second day, I was going to be a little bit of a disruptor. And so the first speaker got up, and he was doing a review of the history and the future of Alzheimer's treatment. And it was drugs. And he was implicating or insinuating that the future might involve some of the same drugs and possibly other drugs. But he was focusing on reusing and reinterpreting the data from the old drugs like Aricept, galantamine, et cetera. And so I got up and I said, well, that was an interesting presentation. And what I'm curious about is what you think about the fact that we know that the immune system and the nutrition and the hormones and, went through the list of the functional medicine nodes that we know affect brain function. And I'm interested in what you think about how these play a role and the future of the field. And in particular, what do you think about Dr. Bredesen's work?
That's Dr. Dale Bredesen.
Dr. Dale Bredesen. And he said, well, it's of some interest, but it's not well documented. And then someone else got up at the mic and said, well, we really feel that some patients try it and they feel frustrated and they feel it's their fault if it doesn't work. And, we went back and forth, basically. It didn't get too heated, but it was definitely, like the epicenter of the morning. And then afterwards, some people came up to me and talked to me about Dale's work. And so I had the last word. And I said, look, this may be a difficult program for people. It's certainly a complex program for people. But I know, and the clinicians that I work with know, that the fact is that we can actually reverse subjective cognitive impairment, mild cognitive impairment, and even early Alzheimer's disease. And even I've had success with primary progressive aphasia in arresting it, not reversing it. And I said, so the fact is that you have to deal with is that is possible, and you need to attend to it. And then I left.
And you dropped the microphone on the floor? And what?
I threw it at him,
Very respectful. I know Dr. Hedaya would not do that. He's too respectful.
So then afterwards, actually, the head of a Canadian consortium, his charge in Canada is to develop or find new technologies that can be helpful in dementia, Alzheimer's in particular. And so he came up to me and he was complaining that he didn't like the way Dale Bredesen's articles were written, that he's a poor writer. Now, I've read the articles and, because I'm in the functional medicine world, I wasn't critiquing them from that perspective and they were very readable to me, but I could understand that it might not be readable. So I told him, it's a different language than you're used to, and you have to become medically bilingual because your patients depend on it. And I told him, he said, maybe we can get some research, maybe get some funding, because I talked about the funding problems. And he said, well, let's see, maybe we get something going.
So, wow. So that's a mouthful. You talked about a lot of things there. That's exciting that there is some interest. Not surprising that the conventional approach remains the conventional approach. And I don't fault a conventional neurology community for saying that there is a paucity of evidence, just not enough evidence. And I mean, that's not untrue. I mean, that is a true statement. The publications that have gone out so far are not randomized. They are not with every group. And I think it's from that perspective, it's a very fair criticism. And the need for more research is also being attended to. There's a couple of groups that are involved and underway and in designing these studies.
Well, so that's true. But I mean, we need more data. There's no question. We need to educate these clinicians. But the other issue that we're dealing with is that most human beings don't like to break out of their paradigm. And doctors are no different, right? Most doctors are not early adopters. Most doctors, when confronted with a different paradigm, they find it uncomfortable and unfamiliar and inconvenient. And that's, for your listeners, there's a guy named Semmelweis, who was actually an obstetrician. And he, back in the late 1800s, I believe, that a lot of women, as you know, would die in childbirth or after childbirth from puerperal fever. They'd become infected. And he discovered that just washing his hands carefully before the delivery, but he was able to reduce the frequency of infection and death. He was so excited that he sent letters to the hospital heads around the country, and he was promptly fired. And it wasn't for 2, 3, or 4 decades later that sterile technique went into the OR, and he was proven right. This, in my opinion, is a case, it's the Semmelweis reflex, where the doctors are frightened by the paradigm, because I know that there are many people who do respond to this treatment, particularly early in the course of the disease.
Yeah, and that's, I think, also a nice analogy. But I also think that this other point that you're making about who responds, because to that other physician's point with frustration about the way that the articles were written, I mean, if he wants, Dr. Bredesen has published a now New York Times bestseller, in layman's terms with good editors and, sort of laid out the whole thing. You can get it in a 20-minute video. We've had him on this show. He's all over the internet. He's been on the Today Show. I mean, you can get his thing in a very distilled way and very simple terms. You can get it in a way that's written for the public. And then he's written hundreds of papers in the past, published in very high journals. So, I mean, he's not unaware of writing in medical terminology and now in kind of lay terminology. But I think I agree with you that more clearly defining who this works best for is extremely important, because I know that we have a number of people of like some really young, like in their 50s and 60s and 70s, have already diagnosed with Alzheimer's, and they have more significant, they're really in a dementia state. And by that, we've talked about this on the show before, but by, when somebody's demented, they've already, by definition, lack the ability to live safely independently. They're not independent anymore. And at that point, I found at least that these interventions are really difficult, extremely difficult for the caregivers. And people feel like, well, it's supposed to work, so why isn't it working? Do you experience the same thing? Do you have thoughts about that?
I do. Obviously, the earlier, the better. The more resources that the patient has, meaning caregivers or people who can, family members or other caregivers who can support. It's a complex, intensive program. There's no question about that. But as I said, I have a patient who I'm treating who's about 74, and he came in with early Alzheimer's disease several months ago and was having trouble getting on the program. And then I hooked him up with a functional medicine coach, and we really got him pulled into the program, and he's doing it, and he's doing great. He's running a lawsuit now and managing all the details fine. He's pretty much back to himself. He had a tremor, it's gone. He had torticollis, it's gone. And he's got energy, etc. But he's complaining, it's all these pills. And I said, John, 5 years ago, or 10 years ago, you'd be talking to me about this, and I'd say, look, we got donepezil, we got galantamine. It doesn't really do that much, but you could try it. And if I said to you at that time, you can change your diet, exercise, and take 50, 60 pills, diet, supplements or hormones or whatever it is, and you will get your brain back, would you do it? And he said, yeah. I said, so don't complain. I told him that. I said, don't complain. Be appreciative that you have this. Is it perfect? No. Is it wrapped just the way we would want it? Is it one pill or two pills? No, it's difficult. But it is clearly superior, and you should be very thankful that you have this possibility, because a few years ago, you didn't have it.
So that's another really interesting point. It's one thing for physicians to be challenged by a paradigm. It's entirely another thing for the rest of us, and for people, for humans, to be challenged by their paradigm to, the next treatment's going to be another drug. And like you're saying, with pretty much any complex chronic disease that we have in this country and sort of worldwide, fallen woefully short in terms of treatments, and disease are just managed until somebody dies from them, heart disease, cancer, HIV, And the interventions, the things that we as patients, we as people need to do, always are going to have a lifestyle component, diet, exercise, sleep, stress, et cetera, and targeted nutritional therapy, et cetera. And I feel like that is a really tough sell if you are seeing patients that are just used to saying, well, do I take one medicine, or do I take it once, twice a day? Or, you know what I mean? And It's just a whole different paradigm for patients too, I think.
It is. It's a whole different paradigm, but I think this gets into the question of who is this program for? Because, as you, I'm sure, have recognized, there are many patients who have dementia who are not really aware of their decrease in function. And if they are, it seems pretty mild, and they're not particularly motivated. Their families are motivated, but they're not. And I think that the personality, the pre-illness personality, has to be assessed. Were they obstinate, oppositional people before? Did they always want to do things their own way? Or were they compliant people who, were cooperative? I shouldn't even say compliant, but cooperative people who do better, who can take on a difficult program.
Right. So do you ever talk to somebody, speaking about who's a good candidate or who's a patient that you think is going to succeed with you in a program like this, and you're coming to with early cognitive impairment or some mild symptoms? Will you talk to them ahead of time and say, like a 5-minute phone conversation saying, tell me a little bit about your symptoms. This is kind of what we do. Are you finding that those types of conversations, you'll kind of head people off at the pass that are just, are just going to end up sort of frustrated and giving up? Or do you like to see people kind of in consultation fully to sort of give them a chance?
Well, no, what I actually spend about 20 to 30 minutes on the phone before I bring someone in for a consultation. And I tell them what the process is in detail. And I ask them about the patient, how interested, how aware are they, how far along are they, and what kind of symptoms are they having, and what kind of person. I try to assess this ahead of time because, I'm a guy who's always hopeful. when a patient comes in, I'm always seeing the healing. I always can see the way out of it, or almost always could see the way out of it, certainly in early cases, And so it's very easy for me to get excited about what I think I can do and how I can help. And so I just rather lay it out up front, even though it's hard for people to know really the magnitude and they can't really know what this means, but at least I'm asking them to assess their resource. And then what happens is, usually people will say, okay, let me think about it. And they talk amongst the family members and, they know what the costs are involved and the time involved and the resources that they need. And, sometimes they call back and say, you know what, we were definitely ready. And it's not a perfect screening tool, but I think it's very important also to, you've seen this, I'm sure, that the caregiver, the wife or the husband, if they're managing most of this, it can take a toll on them. Right?
Oh my God.
Yeah.
Right? Absolutely.
So that has to be assessed also. So that's the way I do it, although you could bring people in and do it in person as well.
Okay, so we're talking sort of everything in the conversation we've talked about up till now is primarily been about Dr. Bredesen's work, but you have been involved in functional medicine, as I understand it, both in general functional medicine and a psychiatric flair to what you do in functional medicine since the late 1990s, correct?
Yeah, it's hard to really delineate where it started. I mean, in my internship in 1979, instead of giving someone K-Lite, to raise their potassium, I gave them a banana with every meal. So,
yeah.
It was a little bit of a...
Just follow the potassium.
That's right. Exactly right. I don't know, why do they have to take this nasty stuff? Why can't they have a banana?
So gross. Yeah, really nasty.
But it developed, I would say, crystallized in 96 or so, right around there. And I've been using functional medicine. I'm a psychopharmacologist and a psychiatrist, but I've been using functional medicine in all my patients since 96, 97. And I do some psychopharmacology, but if you ask me, I'd say I prescribe hormones and antibiotics a lot more than I do psychopharmaceuticals,
Interesting. And I want to touch on this idea of the hormones and antibiotics because, before Dr. Bredesen's protocol was out there, I mean, you were still taking care of cognitive impairment patients, were you not?
Yeah. The first case that I reversed dementia was in 2009. There was a woman who had a Minimental Status exam was 13 and normal is 30.
Yeah, so that's a severe impairment.
So it was pretty severely impaired, and she would get dressed. This is what sticks in my memory. She would get dressed and put her bra on over her shirt. So she was pretty impaired. And actually, I just reviewed the case a few months ago and outlined all the data. And it took 3 months. And she was actually, her Minimental Status exam went up to 28.
In her case, because you mentioned hormones and antibiotics, can you tell us a little bit about the details of a case?
I'm at my computer, and let me see. I could pull it up here.
And as you're pulling it up, it's interesting you mentioned that hormones and antibiotics more so than kind of the classic psychiatric medications, antidepressants and mood stabilizers, et cetera, because, of course, that is kind of from on a certain level, once you get kind of basic core lifestyle pieces like diet, like enough exercise, like getting people good, high quality sleep. And then there's clearly a group of people that's all they need.
Right.
And then there seems to be a whole nother group of people that by the time they make it to somewhere like your office, they're in need of more. Like, can you explain kind of where this idea of needing hormones and antibiotics, where does that come from? Like, why would somebody need that?
Well,
as opposed to like a psychiatric medication?
Hormones affect the brain. They affect every system in the body, and they also affect the brain, right? So whenever you can go to a textbook of endocrinology and look at any endocrine disorder, and the symptoms that are included in that are psychiatric. So you have to always consider, endocrine disorders in psychiatric patients. That's just obvious. And the fact of the matter is now that we know that major psychiatric disorders, for example, depression, are, very tightly linked to hormonal problems such as thyroid and melatonin abnormalities and adrenal abnormalities, and less often reproductive hormones like testosterone and estrogen, progesterone. And I've even had a few cases of people with parathyroid tumors who've had depression. And then, I've had people who have microadenomas, little cysts in the pituitary, and they have a pan-hypopituitarism, and many of their hormones are down. And these are young people, and they present purely psychiatrically. And so you have to look at that. And then, really after a person's been stressed for whatever reason, eventually the hormonal systems give out. Not all of them necessarily, but some of them give out, whether it's chronic nutritional imbalances or chronic psychological stresses or chronic infections. Infections, we know, affect the chemistry in the brain, reduce serotonin, increase dopamine, glutamate, et cetera. There are a lot of changes that are well documented and relating to infections. And many people have chronic infections or chronic exposure to mold, which causes inflammatory problems. So in my population, and the people that I see who are chronically ill with all kinds of chronic diseases, these people very often have various infections. They can have marcons in the nose. They can have mold in the home, at the work. They can have adrenal insufficiency or excessive adrenal hormones and anxiety or depression or insomnia. There are just many, many disorders. And for many people, the final common symptom pathway is psychiatric.
So you mentioned this case in 2009, and I obviously don't want to mention this person's age, but were they like in their 40s, their 50s, their 60s? How old was this?
I'm going to say the 70s, early 70s. She had a long psychiatric history, and she was on antipsychotics. And it's also relevant that people who have chronic depression, for example, or recurrent depression, are 30 to 50% of people with recurrent depression will develop mild cognitive impairment or Alzheimer's disease.
How many?
30 to 50%.
Wow.
Yeah. So, that's a significant risk factor. So she had a history of psychiatric problems. And so she came to me with psychiatric symptoms. My evaluation is 3.5 hours long.
Oh my gosh, what do you do?
I do a complete history. I do a physical exam. I take collateral history. I review all the old records they can get their hands on. And I delve into all the aspects in the functional medicine nodes, all the networks that are involved or might be involved.
We haven't ever had anybody really talk in depth about the functional medicine nodes. Are you able to just kind of
sure.
on the functional medicine nodes and what you mean by that?
So, functional medicine, for those who are listening who don't really know, is a systems biology approach where we believe not so much in A causes B, but A relates to B and C and D relate to A and B, and D relates to C and A, and everything's interrelated. It's a network, right? And so through time and research, Jeff Bland, really the father of functional medicine, and the Institute for Functional Medicine have really sorted these interconnections out. And it comes down to various systems in the body that are relevant to most chronic illnesses. So in my mind, the way I think of it is digestion, nutrition, immune function, which includes infection and inflammation, detoxification, oxidative stress, when mitochondrial function, I put that in there with oxidative stress, energy systems, and hormones, the endocrine area, and genetics, epigenetics, and structural factors that, a person might have chronic pain, for example, or could even be the structure of their membranes, their cellular membranes, but structural factors. And then within that, in a certain sense, in the center of all that is a person's psychosocial network and belief systems and connectivity and lifestyle habits. So the simple way to put all this together for me is I have a little mnemonic. It's DID1. D is digestion, I is immunity, D is detox, O is oxidative stress, N is nutrition, E is endocrine, and then I throw in a G for genetics, epigenetics, and then lifestyle factors.
Sure. So that's a really nice way to put it, that did one G. And so what you're saying is when you look at somebody and you're doing this sort of 3.5 hour initial intake, you're looking at a person's digestion, you're looking at their nutrition, you're making you're surmising about what their level of inflammation and immune function might be, and then sort of ordering tests that will confirm or not your clinical suspicion.
That's right. Now, there are two ways of doing this in terms of ordering tests. So you probably have seen this too. When people come in, their nutrition has been poor, haven't been exercising, they're usually having some hormonal problems. And, a lot of systems can be involved. And so then you have to kind of decide what you go after first, or do you look at it all at the same time? And that depends on the individual. Some people like to take one step at a time. That takes longer because we can do things that are necessary for improvement, but not sufficient. Or you can assess all of the areas at the same time and attack them in an aggressive way if you have the ability. It's harder, but you'll have response quicker.
I think it's important to mention that a lot of these things that are done in a private practice or even in a practice like ours, it's a tertiary care, big institution, is not often covered by insurance. And so that's the other sort of paradigm shift for now. I mean, there's a big personal ante that somebody has to be willing to put up if they want to go with an approach like this. And that for some people is, that is at least for people I see, makes the determination on what they're able to do, how quickly they're able to do, just simple economics. Like, I don't have enough money to do everything, so let's prioritize here. Do you have the same?
No, I don't have the same experience. And I believe that, first of all, if you just look at the economics, let's just say a year of testing and treatment is $25,000, right?
Yeah.
It's a lot of money, right?
Yes.
But people go out and buy a $25,000 car all the time, right? So part of the issue is, there's the motivational issue, but then there's the paradigm that people expect to go to the doctor, have a small copay, take a pill or two pills, maybe change their diet. And so that's their mindset. When we met at the Cleveland Clinic, and I was shadowing some of the clinicians, and I remember this very clearly. One of the clinicians was interviewing a woman who, she was not there for dementia, she was there for some other problem. But the clinician had in her mind that $200 for a test was more than this woman could spend. And so she was, in presenting the need for the treatment, presented it in such a way that she was expecting a no, and she got a no. And it turns out that the patient never came back. Mm-hmm. Now, it's not the clinician's job to make the financial decision for the patient. Clinician's job to say, medically speaking, this is what you need. This is what it'll cost. This is the cost if you do it, and this is the cost if you don't do it. And, then the family, they make the decision. But a lot of doctors this is what I see. I actually supervise and train a group of psychiatrists in functional medicine.
Oh, really?
And almost all of them have the same problem. They're always making the decision and worrying about the patient's finances, and they don't even have the data to come to their conclusions. They don't know they're just projecting what they think the situation is. And it's a big mistake because in the end, they are actually damaging the patient because, as you know, if you develop dementia, it's going to cost a lot more than $25,000 a year, right?
Mm-hmm.
So,
and there's the emotional costs and also all the other things.
Well, yeah, I mean, family losing time. The family, sometimes people have to leave their work to take care of their demented parent.
Yes.
So It doesn't mean everyone can afford it. I'm not saying that. I'm saying that you need to present the medical necessity and let the patient, the family, make the decision.
That's a really good point. Yeah, it always surprises me what people are willing to do. I'm sure you have been as well. I'm fairly consistently sort of amazed and inspired by the people I see. It's the commitment from most of the people that come to see us is just pretty astounding, actually.
Oh, I found the case. Yeah,
so what was the key here? I mean, can you kind of give us some general idea of the evolution of this case?
Yeah, I've got it outlined here in a nice chart. So this is a woman who came to me in September of 2009. Her Minimental Status was 15.
So again, the total score is 30. The Minimental Status is, once you get below, on that particular test, 24, you're already pretty impaired. Below 20, very impaired. 15 is a bad score.
Right. And so that was September of 2009. By January of 2010, she was between a 23 and a 25. By December, this is 15 months later, she was at a 28 over 30, which she maintained for another year. And then she was lost to follow-up. I don't know what happened. She came in, she wasn't depressed, she wasn't anxious. Her brain scan showed she had volume loss in her brain and small vessel disease and her mild dilation in her lateral ventricles, atrophy in the left temporal, left frontal, etc. So, and perivascular white matter hyperintensities. So there was a mixed picture. It wasn't just Alzheimer's, it was vascular dementia also. And let's see what we got here. So her vitamin D was a little bit low. She had her nighttime cortisol was actually high, and that was probably impacting her sleep. And of course, she's postmenopausal. So I put her on estrogen, Vivel dot patch, which is bioidentical estrogen. And I put her 2.5 months into the treatment. 2 months, 2.5 months. Put her on thyroid. Her thyroid numbers came back. Her TSH, the mean TSH in the American population in the NHANES study, which was about 17,000 people, is 1.4. So that tells us how hard is the pituitary gland working to stimulate the thyroid. Her TSH was 4.08, which by half the endocrinologists in the country would say that's too high. Half would say, well, she's still in the normal limit, the upper limit being 4.5. I observed, changed the nutrition, but her TSH remained elevated when I rechecked, so I put her on Armour Thyroid. That seemed to help significantly. And then her homocysteine was elevated, so folate and B12. She had a lot of amino acid deficiencies.
And how do you measure amino acids?
So I do plasma amino acids, okay. And I think it's better than urine just because you avoid the whole issue of what the kidney is doing, a little more direct. She had a few mineral, her magnesium was quite low, actually.
And do you measure a regular magnesium like a serum, or do you measure a red blood cell, RBC
I
magnesium?
do red blood cell magnesium.
Okay.
And her manganese was low. She had, her inflammatory markers, her CRP was 2.2, so there's some inflammation there. Most people are under 1. That was the highly sensitive CRP, so that's elevated. Her TGF-beta 1, which is a marker of inflammation, was normal. Her C4A, another marker of inflammation, upper limit of normal was 2,800, and she was over 7,000. And that actually came down with treatment very nicely. She had a B12 deficiency anemia, and her sodium was low. And she was ApoE3, 3.
So not a classic high-risk Alzheimer's patient.
No, not a classic high-risk Alzheimer's patient. And in her stool, she had a lot going on. Pancreatic elastase, I think it was low.
So Pancreatic elastase, meaning that there was some evidence that she probably or may not be digesting foods as well, because pancreatic elastase is a surrogate or say a marker, an indicator for somebody having, if that's low, then maybe they have low digestive enzyme function.
That's right. And her folic acid was subnormal. So that's pretty much what we've got. And
so those are the things you measured, and then you just gave her those things?
That's what I did. And, I saw her every few weeks, I guess, and she did quite well. I would say by my standards, I don't know about yours, but this is a pretty straightforward, relatively simple case.
Yeah, that's what I was thinking. I was thinking, wow, that seems like that's a pretty good one. Put a ribbon on it, that's a pretty good one.
Put a ribbon on it, right? Yeah.
One of the things that I think right now we're with functional medicine and things like functional medicine, if there's anything like that, I think maybe there's a little bit of some hype, there's some sensationalism around it. It's very exciting because we all have cases that are just extraordinary, knock it out of the park, just amazing types of cases. And where people were extremely sick, and it was a well-documented case from a sort of a conventional medicine standpoint, whether it's an autoimmune disease or dementia or heart or whatever. And they go through these interventions and they get phenomenally better. And nobody really wants to talk about, how many people and what percentage. But for your case, let's say going back to some of the cognitive patients, right? For people that are not, they haven't lost their independence by the time they've seen you, or they're not severely impaired where they have catastrophic brain function loss. I know you don't probably know, you don't have the numbers in front of you, but if you estimate how much better can people, who's getting better, what percentage of people are getting better for yourself and for people that you talk to that go through these types of programs, and how much better can people expect to get? I mean, are they going back to when they were 20 years old and they're 65 years old, they're 75 years old?
Okay, these are great questions. Great questions. So let me tell you a little story first, and then I want to answer it specifically with regard to the cognitive decline.
Yeah.
So when I started doing the functional medicine, and then in late 90s, and then in 2001, I wrote a book. It was a bestseller, 4 pages in the Washington Post. We had hundreds, if not thousands, of phone calls for months. I mean, we had 9 lines, and you couldn't put the phone down without somebody calling, right?
Yeah.
So it was a very high volume, and people were excited. The patients were excited. And I was very careful to screen for people who were motivated before I would see somebody. That was like my primary criteria.
Right.
So I got people who were motivated, and I was treating people with psychiatric problems. But these are people who are treatment resistant by and large.
What is treatment resistant?
Like treatment resistant depression.
Meaning they had medication and it didn't work.
Yeah, they usually were on 2 or 3 psychiatric medicines and they weren't doing well. Well, they were doing okay, but they were having a lot of side effects and, they weren't happy. So I did the functional medicine approach, and I prefer to do the approach where I look at all of the factors, I test all of the factors, and then I intervene sequentially in all of the factors as quickly as possible. That's the way I like to do it. It's more intense, more difficult, but I feel you get quicker results, and the patient isn't going to get burned out because they're waiting and waiting to get well. So after about a year or a year and a half, I was blown away by how I was really not doing much psychopharmacology. And I was like a master psychopharmacologist. I mean, the drug companies loved me. They sent me to Portugal to go to conferences, the whole thing, right? So I'm not really doing much psychopharmacology anymore. And I'm thinking, gee, I wonder if I'm paying selective attention to my successes. Maybe I'm just forgetting about the people who fail. So I went and did a retrospective analysis of the 24 patients sequentially that I had seen who stayed in treatment with me. And I was looking at their depression inventory because I think I was treating mostly depression with anxiety, which could have been bipolar depression or could have been unipolar depression, but depression was the presenting symptom, and with anxiety. And what I found that at the start, the mean Beck depression inventory score a normal Beck Depression Inventory score is under 10. And the mean, the average, we'll call it, Beck Depression Inventory score in these 24 people was 34. This is severe, high, moderate, low, severe depression. And then I was in the habit of testing the Beck Depression Inventory every 3 months or so. And basically, by 10 months, all of the patients were under 10. And I did not make a single change in their medication. Okay. So, except for one patient, I made a change. So the functional medicine, in my mind, it was like, okay, this stuff works. So the first thing in answering your question, when you say how many, in somebody who has some degree, whether it's subjective cognitive impairment or early dementia, the first question you have to ask yourself is, well, first, let's just talk about people who do the program, not people who kind of do the program, because if you kind of do the program, you kind of get well. Okay,
good point.
But if you do the program, let's ask, if you do this program, what percent of people who have mild cognitive impairment get well? I'm going to say, and I would say it's on the low end, I'm going to say 2/3. That's what I would say. But I don't have a large data set. You know what I mean? Now, do they return to age 20? No, I don't think so. They may still have some impairments, but they're significantly better. And they notice an improvement, and their significant others and family members notice an improvement, and their scores improve. And their general health improves, and they usually end up on less medication and have more energy and more cognitive energy. But it's a little bit of a brittle situation because you really have to stay on the program. There's not a lot of wiggle room here, in my experience. If you cheat on your diet, you pay the price the next day or 2 days.
I've seen that in a couple of people where they really are. Yeah. That's amazing how brittle. So not everybody, but some people are.
Yeah. So I would say that. Now, the more advanced you are, obviously there's more damage to the nervous system, the less likely you are to return back to where you were. But how much cognitive function can you recover? And also what, the brain is very plastic, right? And different neural circuits, they serve many different functions, right? A network, we think of neural networks, right? A circuit for this or a circuit for that. But the neurons in the brain can serve many different functions, and they can actually take over different functions. So, it's possible, we're not there yet, but it's possible that there can be some recovery of functions, behavioral, cognitive functions, even though some of the neural networks are damaged, that other neural networks might be able to take over time, slowly, and to, maybe a limited degree at this point. So that's kind of how I see it. And then just the last thing I'll say is, like this case I presented to you where, her Minimental Status was 15 and she got up to 28 in about 3 months. That also tells you what's possible. And she had a dedicated husband, and he did what he had to do.
So kind of just as the last thing I'm wondering about here for this conversation is, so now you have somebody who knows that their mother or father developed Alzheimer's, and when the dad was 79 or 82 when he got it, and it showed signs maybe 5-6 years before then, kind of mid 70s, early 70s, and they're thinking, well, I'm 45, I'm 50, I'm 55 years old, I'm 60 years old, 65 years old, and I feel I may a little slower, I'm not quite where I was once, but I do not want to end up like my dad. I saw what happened in the nursing. I just, what would you say are the kind of key things, 1, 2, 5, 10, whatever you think, what would be kind of the minimum data set that you think somebody should kind of get in terms of risk assessment, and then also maybe like basic prevention strategies?
I would say I would look at methylation.
What do you mean by that? What do you test?
Okay, I'm sorry. Yeah, so I would be looking at, I would get a complete blood count, which is a $6 test, CBC. So you could look at the size of the red blood cells and the number of red blood cells, and look whether there's any abnormality in the size of them, because that'll give you clues about not only iron, but also B12 and folate. You want to check a homocysteine, which will also give you information on the folic acid and the B12 story. And those are simple tests to do.
Yeah.
Clearly, cholesterol management through diet, ideally, because if you manage it through diet to the degree that you can, that means you're going to move into a Mediterranean diet, which has lots of antioxidants and very rich diet in terms of color and healthy fats. And, so your weight's going to come down, and then you're going to look at glucose measurements. So the simplest one, I think, is a fasting insulin. And if you can get that to 3 or 4 or something like that, then you're probably good, assuming you don't have type 1 diabetes. And I would obviously avoid head trauma. And I would certainly check thyroid function. So TSH, free T3, free T4, and make sure that your TSH, the numbers are close to the median for the country. So TSH of 1.4. And the free T3, which is the most active thyroid hormone, should be about in the mid-range, 3.2 or so. And probably you want to check reproductive hormones, particularly in women. You just take a history, right? Did early oophorectomy or early menopause or something where they had a estrogen withdrawal at a young age. I think the cutoff, they say, increased risk of dementia at 40. Right. And then, testosterone, obviously important. And then zinc is a big one. And this is not expensive. I like red blood cell zinc and copper. Zinc plays a major role in the hippocampus and also in the immune system. Mm-hmm. And you want to keep your zinc to copper ratio at the right number, which if you use red blood cell, it's 16 to 1. And then I would probably, if there's any digestive problems, those need to be addressed. Some inflammatory markers would be good. Maybe they're not CRP, but that's really more for acute problems. Probably I would go for a C4A or TGF beta 1 and a SED rate, something like that, just look for inflammation. So that's probably, I might be missing 1 or 2, but that would be a screen. And I think that's at reasonable cost.
And anything that you would advocate for other than, okay, I know Mediterranean diet's good. I know exercise is good. And I know that sleeping enough, whether that's 6.5, 7, 8 hours, and making sure I don't have sleep apnea. I know those things are important. And I know managing stress is important, right? We everybody knows that, whether they do that or not, that's another question. But everybody sort of, hopefully by now, has some sense that those things are important. Anything else on other than the kind of low risk, high reward lifestyle things we mentioned? Anything else you could add, being social to that? Whether you have a family,
being bilingual. If you have, in the case of Alzheimer's disease, actively bilingual. So you're actually using 2 languages frequently, actually delays the onset of Alzheimer's by 4.5 years. It doesn't stop the degeneration in the brain, but other parts of the brain are able to compensate so that, you really have a longer functional lifespan.
Awesome. I have many, many other questions I prepared for today, but I don't think we can get to them. We may have to have another time if we can find some time that you're able to.
Sure, it'd be my pleasure.
Thank you very much. If for anybody that would like to come see you as a patient or connect with you, how can they do that?
I have a website. It's Whole Psychiatry, like Whole Foods, the W. I came up with it first before they did. And just saying. No, but that's my website. There's actually a lot of resources on there, and my contact information is there.
Excellent. So thank you so much, Bob. So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website, where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.